Plain films of the limbs are done quite frequently still. Every time I go to an orthopedist, the first thing they do is they take you into the room and they have an x-ray done of whatever it is you can say the pain is emanating from. So you do have to be able to recognize major structures of the bones. I'm not going to go over every one of these. There's no point in doing it. You can study this at home on your own. I'll just point out a couple of things. One is that the coracoid process has a base, right here where it attaches to the scapula, to the rest of the scapula, and then it has a long beak-like process which extends laterally. So when you're looking at this thing here, you might be tempted to think that that circular thing is the coracoid process. In fact, that's just its base. The actual coracoid is seen extending very far from that thing laterally. That's a real prolongation. Secondly, this picture shows the lesser tubercle on which subscapularis attaches. It has very obviously different and distinct from the greater tubercle. That's true, they are very distinct. But in this person, you can see that the lesser tubercle overlaps the greater tubercle in a way that's not seen in this drawing. And this is the reason why. Here are CT scans of the upper end of the humerus, big bump greater tubercle, small bump lesser tubercle. Here's the glenoid cavity of the scapula, and then here's the scapular blade. And what I've done is I've positioned these two tubercles as they would be in real space if the person was standing in completely neutral rotation, like I am standing now. Not anatomic position necessarily, just plain old neutral rotation. In that case, if you do a plain film of this person, the lesser tubercle will overlap the head of the humerus. Here's a person in internal rotation, with the lesser tubercle having been moved internally. And if you do a plain film of this, the lesser tubercle will be very distinct as a bump on the medial aspect of your upper humerus. And here's a case where the person has put their humerus in external or lateral rotation. And when you do that, the lesser tubercle on a plain film overlaps the greater tubercle. So this is the person that we saw. And that tells us the reason this lesser tubercle is here overlapping the greater is because that was taken in lateral rotation. It is very common when you do a shoulder x-ray to take one set in lateral rotation and one set in medial rotation. And here's the person's position in medial rotation, where the lesser tubercle now appears as a genuine bump on the medial aspect of the bone. So you just have to be aware when you're looking at a shoulder x-ray. It makes a big difference, the state of rotation of your shoulder, how things actually appear. Now, these bones of the upper limb are all preformed in cartilage and ossified through a process called endochondral ossification. And there's an ossification center for the shaft of the bone. And there are a variable number of ossification centers for the proximal and distal ends of the bones, which are called epiphyseal centers. You have to know that they exist. And so I'm showing you them. You don't have to know. I wouldn't think the timing of when they develop. I don't know the timing of when they develop. So, and I don't think Dr. Larson does either. So if we don't know it, you don't have to know the timing of when they develop. But you can get an idea from looking at this picture. This is 10 months old, a 10-month-old child. There's very little going on down here at the elbow region. We'll look at the elbow later. But you can see here there is the epiphysis for the actual head of the humerus. That's called the humeral capital epiphysis. And there's one here for the greater tubercle of the humerus. There is an epiphysis for the lesser tubercle. I don't know if it's developed at this stage or not. It's very hard to see anyway because it's very small. But there is a separate epiphysis for the lesser tubercle. Here's the shaft or diaphysis of the humerus. The scapula, as you know, is really two ossification centers. One is called properly the scapular ossification center. That's for most of the bone. The other is called the coracoid ossification center for the coracoid process in the upper third or so of the glenoid. And here's the coracoid ossification center distinct from the rest of this scapular ossification center. So you have to know that these things exist. And when you see an x-ray of a kid, you don't say, oh my God, look at all the breaks that have occurred in the upper end of this humerus. Now, what's wrong with this person? It has nothing to do, this has nothing to do with ossification centers. I'm through with ossification centers of the shoulder. All right, not so obvious when you look at this. It's going to be real obvious when I show you the volume rendered 3D image of what's wrong with this person. This person has a complete transverse fracture of the scapula. And interestingly, now that we've seen what it looks like in the volume rendered CT, we can go back and look at the image and see more clearly what's wrong with this person. I think a good orthopedist would have spotted it on the plain film, but none of us are good orthopedists. You can see this little jog right here. You can see that little jog right there, so that's part of where the scapula is fractured. And you can actually see this little white line and things like that, which is along the fracture line too. Here it is there. So you can tell from this, now that we know that something's wrong, but it's so much better if you can get a CT of this thing, then you can see exactly in great detail how this bone was fractured. Not a fracture. There's no fracture here, but there's something wrong. This is the lateral end of your clavicle. This is your acromion. There's a joint between those two called the acromioclavicular joint. These bones are not supposed to be this far apart. They're supposed to be much closer, separated only by the cartilage that's on their surfaces. So this is a person that's had not a separation, a separated shoulder, as Dr. Larson then says she told you, is a genuine dislocation of this joint with tearing of the ligaments which run from the coracoid, which is right here, up to the clavicle, called coracoclavicular ligaments. And when that happens, the joint is said to be separated, and the clavicle usually elevates because it's not being held down near the coracoid. This person does not have a separation. It's called not a word you're going to need to know in this course, called the diastasis or diastasis of the joint. The surfaces have been pulled far apart because the actual ligaments which run between clavicle and acromion have torn. But the ligaments which run between coracoid and clavicle have not torn. So it's like almost a shoulder separation, but not as bad as one because the coracoclavicular ligaments are still intact. The trauma that produces a shoulder separation is the same as one that produces this diastasis, but it's just of a milder degree. I just put this in for interesting, because I think they're interesting anyway. Now this one, people should be able to tell what's wrong, in my opinion. All right. No one here is quite prepared to enter the orthopedic clerkship right now. I can't understand why. If I show you the volume rendered from the CT, you'll see what's wrong. Here's a clavicle piece. Here's another clavicle piece. This has a complete fracture of the collarbone. And now you can see, too, there's clavicle piece and other clavicle piece. There. Here it is here. One piece and the other clavicle piece. These bones break, in other words. Elbow. Again, I'm not going to go over all these things. You can study this on your own. In fact, I may not go over any of this. I just want to make one point, which is a very minor anatomic detail point, but that's what we all live for. This portion of the ulna, this long portion which extends superiorly from where the coronoid process is, that's called the olecranon. There's a bump on it, which is called the olecranon process. So the word olecranon and olecranon process are not synonyms. The olecranon is a chunk of the ulna. The process is a bump on the olecranon. Here, in fact, shows you the olecranon process, but it's this whole thing is the olecranon. This looks like it really should be something interesting. It's perfectly circular. And what it really is, you see it in lateral plane films, is that the spool of the trochlea has a groove, and that groove in the spool of the trochlea, when seen in lateral view, makes this perfect, beautiful circle. So that's just what it is. So in case you might have thought, well, it's an epicondyle of some sort, but it's not. It's just the groove in the trochlea. There's the diaphysis of the humerus, the diaphysis of the radius, the diaphysis of the ulna, and these bones develop epiphyses, distal epiphyses for the humerus. We looked before at proximal epiphyses of the humerus. The humerus has a couple or three or four maybe distal epiphyses. The first one to form, you don't need to know timing, is the one for the capitellum, which is the part of the bone that the radius articulates with. Two different shots, same person. Go on to a little older, that's 2 years, 2 months. Here's someone a little older than that, 3 years, 4. The capitellar process is bigger. Now we start to see the epiphysis for the medial epicondyle, and we start to see the epiphysis for the head of the radius, which is the proximal radial epiphysis. A little older yet, medial epicondylar epiphysis is bigger, capitellar epiphysis is bigger, proximal radial epiphysis is bigger. You know, these bones are preformed in cartilage, so what we're seeing is cartilage at the ends of these bones being replaced by bone. The humerus, if you took it out of that child, if you killed it, took the humerus out, and that's what, you know, that's what we do in our spare time. If you take the humerus out of the child, it will look like a humerus. It's just that the distal end will be made of cartilage, and the proximal end will be made of cartilage. It doesn't look like it's missing those things. What we're seeing now is that cartilage being replaced by bone. And that's why you can see it on an x-ray, whereas when it's cartilage, you can't see it on an x-ray. Later yet, a nice proximal epiphysis. The radius is quite big. You can also see clearly at this angle the epiphysis for the lateral epicondyle, and there's a little epiphysis, you can see it better here, for the olecranon process. So these are all epiphyses around the elbow joint. Yeah.
Is one of the epicondyles broken off?
Actually, you know, you could think that. This is the medial epicondyle, which is always the biggest one, plus this is the radius. I mean, here's the radius here, and the ulna there. And here's the medial epicondyle, so it certainly couldn't be that one. Could it be the lateral epicondyle here? The lateral epicondyle is never that big at all. But look at the upper end of the radius here. That's beat to hell. This radial head, it doesn't look so bad here, but that's an artifact of the way it's overlapped by the humerus. This is a fragment of the radial head. The person's radius head has just been fractured off of the rest of the radius, and something that, when I looked at this initially, I sort of got an idea that it was a fracture of the radial head, but I never would have guessed the second thing, which you can only see on lateral x-ray. There's a complete dislocation of the elbow in this person. This is why you do both AP and lateral films in everybody. You cannot tell things in 3 dimensions if you just do one of them. So this person has a fracture of the radial head and a total dislocation of the elbow, with naturally ulna being displaced posteriorly. This is how it's fixed. You saw off the remaining part of the radial head and you put in a nice new metallic one.
What kind of force could cause such an injury?
Obviously one which is directed largely posterior. I mean, I don't know if the person fell from a great height and landed, you know, like that, or tried to stop himself in an automobile by pushing against something, but it's a posteriorly directed force. Supero-posteriorly, probably. And so that's how this is fixed. By these things don't heal. These heads of bones. You just replace them. All right. That's what this lecture is. Reasons to stay in bed and study anatomy. Obviously, a fracture of the ulna and a fracture of the radius. This is how these things are repaired in modern orthopedics. Put a plate with screws and you bring the two opposing ends of the fractured bones as close together to one another as you can in alignment. And the reason you do this is because you want to take advantage of something called healing by direct cortical reconstruction. If you can put the broken ends very close together so that they just about match, the healing goes much more quickly and produces a better result. So this is what you can do. This is what you do if you can do it. All right. Here is a different fracture. Here's a person whose humerus was fractured with all these little splinters. Here, the shaft of the humerus was fractured here. Also, there's a little line there, which is a fracture in through the surgical neck of the humerus. So this was not really a candidate for plating and screwing, which is what you would like to do if you could, partly because of all the little splinters here, but partly because if they had stabilized the shaft of the humerus with a plate, that would put extra stress on the surgical net, and it would probably get worse. So this was treated by putting this individual in a sling and saying, come back in a year and you'll be fine, essentially. Here's the healing process. This is called healing by callus. If you cannot put the ends of the bones together and allow direct cortical reconstruction, which is a faster, ideal way of healing, you rely on the fact that when this happens, there's going to be a lot of bleeding around here. So there'll be what's called a hematoma. Hematoma is just a swelling due to blood accumulation. That blood will eventually be invaded by connective tissue cells, fibroblasts, and will be turned into a highly vascular fibrous tissue. So the hematoma, the blood will be replaced by highly vascular fibrous tissue. That fibrous tissue will then start to turn into cartilage. That cartilage will calcify, and the calcified cartilage will be replaced by bone. Generally, the bone starts to form a little after the first month. There's a little whiteness there that's probably some calcification of the cartilage. It's more obvious here. You can see the little white area there and a little white area there. That's probably the beginning of bone formation. Now you see a big white lump here and a big white lump there, so the bone is well along the way to forming. Big bump, big white bump. Now it's getting quite dramatic and strong, and then this is at a year. So this is completely healed now through this process called healing by callus. And this will eventually straighten out. I mean, there's a lot of irregularity in shape here, but over time that will straighten out. I just don't have any later x-rays of this. So there's two basic mechanisms whereby fractures can heal. One is the normal one, and the other one is plating, which only doctors can do. So here's a person who's a different person than the first gentleman we saw, who broke his forearm, both radius and ulna. I don't see the break in the ulna. It's right here, the break of the ulna. All right. And they plated it and figured he'll do fine. 4 years later, the guy rebroke the same forearm, and he broke the plate here, and here he broke the ulna proximal to the plate, and he also broke the distal end of his ulna as well. I don't know what these people are doing. Now, they took a look at this and they said, you know, I can see healing by callus here in the radius. So he didn't come in immediately. There's already healing by callus. You can see it here in the radius. So they said, you know, maybe we should just leave this guy alone. You know, man, look all of these heal by callus formation. So 3 months after that, he comes in again. There's a nice callus here for the ulna, a nice callus forming for the radius. But look at his arm. It's healing by callus formation, but with an angle of 35 or so degrees between the distal. So they said, that's no good. I mean, this is healed, but the whole forearm is misshapen. So they broke it again and put in new plates. I do not know if he broke it subsequent to this. But I show you these because I find it interesting. He also obviously must have broken his humerus at one point because here's a plate there. All right. These are the bones of the wrist, the carpal bones. Here they are. My mnemonic for these bones. Triquetrum lunate scaphoid, trapezium trapezoid capitate hamate. That's my mnemonic. You may have another one. It works. I forgot pisiform. This thing here on the hamate, what's that called? Yeah, the hook or hamulus of the hamate, and you can usually see it on a plain film. The distal end of the scaphoid usually looks thicker than the rest of it because that's where the tubercle of the scaphoid lies. There is one mnemonic that I do use in these wrists because I always have a tough time remembering whether trapezium comes first or trapezoid comes first as I'm passing from one side to the little finger side. And because I know you all wish to become MDs, trapezium comes before trapezoid. The M comes before the D. No? That doesn't appeal to you? All right, works for you. All right. Now, when you are born, and all of those bones exist as little cartilaginous bones that look just like they're supposed to, but don't show up on X-ray because they're made out of cartilage. And eventually, one by one, each of those wrist bones develops an ossification center in the middle, which then spreads and turns the whole bone except for the surfaces where it articulates other bones, and that's always done by cartilage. Articular surfaces are cartilage. Turns these things into bones. This must be this little white dot. It must be the ossification center for the hamate. That's the one for the capitate. Here the hamate and capitate are bigger. Now we see the distal epiphysis of the radius. We also note here that if you look at the metacarpals, they are not fully ossified. Proximal phalanges have a proximal epiphysis here. Here again in this layer, you can see proximal epiphysis for the proximal phalanges. Here it's very clear the distal epiphyses for the metacarpals, except for the first metacarpal, which ossifies like a phalanx does. So it has a proximal epiphysis. All the phalanges have proximal epiphyses. Metacarpals have distal epiphyses, except for the first metacarpal, which has a proximal epiphysis. In terms of our wrist bones, we have hamate, capitate. Now we start to see the triquetrum come in. And distal epiphysis for the radius. What must this be? This must be lunate, would be my guess. It is. Here's lunate, triquetrum, hamate, capitate, trapezoid, trapezium, and now the scaphoid is there as well. And then we get to where it looks by 8 years, pretty much like an adult. The last one to come in is the pisiform, which is right here. That's the last of the carpal bones to ossify. Here's not a young person. Let's look at the bones here. Triquetrum and pisiform are there. Lunate, scaphoid with its tubercle. Hamate, capitate, trapezoid, trapezium. In a slightly different angle, you can see the trapezoid and the trapezium more clearly separate from one another. As you rotate the wrist, these bones become either less or more discernible. Anything odd about what's going on here? Because all bones that form joints should be separated by a clear area, because the two bones contact one another with cartilaginous surfaces. All right? For example, here's the nice clear area between the scaphoid and the radius. Here's the clear area, black. By clear, I mean black. Between the lunate and the radius. All joints, the bony surfaces, should be separated by the cartilage which forms the contact surface. No separation between this person's trapezium and her thumb or pollicle metacarpal. And that's because the cartilage has been worn away by osteoarthritis. Osteoarthritis is essentially death of the cartilage which forms joint surfaces. So the cartilage gets worn away and dies, and then the two bony surfaces, they're not fused with one another. The two bony surfaces between trapezium and pollicle metacarpal and thumb metacarpal now contact one another without the clear area in between them. When these bones start to touch one another with no cartilage separating them, it's very painful. So this person, every time she moved her thumb, and that always involves movement of the carpal at the carpal metacarpal joint between trapezium and the first metacarpal, it hurt her. It hurt her so much that she couldn't use her thumb. So how did it was treated? This is how it was treated. Anybody see how it was treated? One on the right shows it very clearly.
Took it out?
Sorry? You're right. They took it out. They took out the trapezium. Generally, if she has a palmaris longus, they'll take the tendon from her palmaris longus, cut it, separate it from the muscle, roll it like a rolled anchovy, and stuff it in there between the metacarpal and the radius. And I think the name of the procedure is something like an anchovy procedure or something goofy like that. But probably they did that here. And they just used that to separate the pollicle metacarpal from the radius, and the pain goes away, and the person is very, very much happier than when she had a painful joint. So they just called it trapeziectomy. Different case. Here's a person who has, let's look at our bones. Here's pisiform, this is triquetrum, that's lunate, that's capitate, that's scaphoid. Right. Here's trapezium up here, and it's overlapping the trapezoid, so I don't see it so well. This person has a fracture right through the middle of his or her, I'm not sure which, scaphoid. This is a particularly bad fracture to have because the blood supply, all bones need blood supply or they die. The blood supply to the scaphoid enters its distal part and then travels proximally to feed the more proximal part of the bone. So when you fracture your scaphoid right through the middle, you risk cutting off the blood supply to the proximal fragment, and it will die eventually if it doesn't get blood. So this was done in February, and they decided, boy, we want this to heal, and it's going to be best if we can bring these two fragments close together. Maybe, the blood supply hasn't been completely interrupted, or we can promote the blood supply going from the distal fragment to the proximal fragment. So they put a pin in it and pinned the two fragments together. Here's a year later. There's still no healing. You can still see a radiolucent area right there showing that the proximal and medial and distal fragments of the scaphoid haven't healed. So then they took the pin out. I don't know whether they hoped something would happen when they took the pin out or whether they just got frustrated. But they took the pin out, and now you can see without the pin how clearly separate distal and proximal fragments are, as separate as they were when the fracture occurred, which was over a year ago for this individual. So then they said, okay, this is not good. So let's take a little bit of bone from our radius. That's why it looks a little bit more radiolucent here. They chipped off some of the cortical bone of the radius, and they jammed it in between these things as a bone graft, hoping that that would promote cure. And here it is, no healing whatsoever. So this has been a failure to treat this. Must have been done in some hospital other than Stony Brook, huh? Although how I would get access to the x-rays that was done somewhere. And the radiologist took a look at this proximal fragment here. And I agree with the radiologist. It's denser white. It's more radiodense than it should be. Now, when bone starts to die, peculiarly, it collapses and it gets more radiodense. And this is a sign of what's called avascular necrosis. Avascular necrosis is death of a bone due to its loss of blood supply. And it usually shows up then as a more radiodense structure due to collapse than it was before. So they decided that this person has avascular necrosis of the proximal portion of the scaphoid, which is untreatable. You can't bring it back to life. That bone is dead. So this is how they treated it. They took out the entire scaphoid, lunate, and triquetrum. It's called a proximal row carpectomy. They took out all of the bone, because they can't just take out a bit of the scaphoid, the whole thing would be totally unstable. So I don't know who discovered it, but apparently if you can just use your capitate as an articular bone for the radius, and that gives you a more stable joint than leaving in a fragment of a scaphoid. So they just take out the whole thing. I guess that helped. Oh, now, I don't expect you to answer anything wrong with this. Here's a patient who comes in and is complaining on pain on the ulnar side of her wrist. Pain in the ulnar side of her wrist. They take these x-rays, the radiologist says, there's nothing wrong. All right, let's order a CT. So they did. Now, we're going to follow the CT from the distal radio-ulnar joint, distally through the wrist bones. And I've labeled these, and as we go distally, this line will tell us the level of our section. So we're still at the distal radio-ulnar joint here. Now we're actually sort of through lunate radial joint, but if we go a little bit further, we'll catch the lunate. So here's just the beginning of the lunate, and we're at the tip of the ulnar styloid as we're losing it. We go a little bit further distally, we still have lunate, and we are very close to catching the back edge of the pisiform. And we also just catch the proximal part of the scaphoid. So we keep on going distally. We see more scaphoid, lunate, pisiform. And this little triangle here marks the apex of the triquetrum, so we're just catching the triquetrum on that side. Everything looks fine so far. Everything looks fine. Now we're getting up to the joint between the head of the capitate and the scaphoid and lunate cup. So we're going to see the head of the capitate right there. Keep on going. Here's the tubercle of the scaphoid that I mentioned to you, projecting ventrally from the distal part of the bone. Keep on going. Now right here, we're right at the proximal apex of the hamate, so that starts to appear. And now I'm going to keep on going. When anybody sees something wrong, they can tell me. Well, you should have. Do it again.
The hook of the hamate broke off. The hook of the hamate fracture?
Yes. The hook of the hamate's fractured straight across. So she had pain on the ulnar side of her wrist because of fracture. I don't know how it happened. Maybe she landed or something, on the bone. Hook of the hamate fractured right off the hamoid bone. Not really. It's like you can see in a plain film. It's just too hard to see in a plain film. But that's what happened to her. And now, if you take a look at the sagittal reformat of the CT, because all CTs are taken axially, but then you can computationally reformat them. Here's the sagittal reformat through the hamate, and you can see the hook is fractured across. And then in the volume rendering, you can see right there too the hook of the hamate's been fractured across. Reasons to do CTs. Here is a person, just so you know, bad things can happen when you get, well, you don't even have to be old for this to happen. Rheumatoid arthritis is an autoimmune disease, I guess. You must know more about rheumatoid arthritis than I do. No, you haven't done that yet? All right. So then I can say whatever I want. So this is an autoimmune disease, and it just eats at your joints like they were butter. And these bones are all fused with one another. This person had totally immobile, probably painful wrist. Look at the disease is even eating up the distal end of the ulna here. There's no ulnar head. There's nothing left. There's nothing you can do with this person's wrist. I don't think you can replace it with anything. I don't know. It's just hopeless. And you also see the disease has affected the metacarpal phalangeal joints too as well. It's a very bad disease, rheumatoid arthritis. All right. We're going to be looking now at MRs. And there's one thing I want to say about MRs of the shoulder. Now, this is just volume rendering from a CT, not from an MR. Looking at a person straight at their back, a posterior view, showing the scapula and the humerus, clavicle, blah, blah, blah. I have rotated, or actually the computer, I've rotated it so, all right, so I'm staying here and you're looking at the back of my left shoulder. And now you're looking at the back of my left shoulder slightly obliquely. Even more obliquely, even more. When I rotate 45 degrees, that's what it'll be like. This plane formed by the scapula is called the scapular plane. It is about 45 degrees to the coronal plane, or for that matter, to the median sagittal. So I'm just rotating it so that now we are looking right down the vertebral border of the scapula towards this axillary border to point out one thing. If I take MRIs, which are in the scapular planes, that they are passing this way, the sections go like this. So from front to back, like that. So I've got one section. Something people don't really appreciate, because the upper portion of the scapular blade is angled relative to the lower portion of the scapular blade. You get the supraspinatus in the same sections as the subscapularis. You almost always think to yourself, gee, supraspinatus and infraspinatus, they're on the back, so any section should get them together. But it's because of this different angulation here between the upper part of the scapular blade and the lower part that a perfect section in the scapular plane is going to get through supraspinatus and subscapularis. And then really you don't get infraspinatus until virtually supraspinatus is out of your section. So I just want to say that because that'll explain what we're going to be seeing. So here is the plane of the section in an MRI in the scapular plane. I mean, it's never perfect. They never get these things in a perfect scapular plane, but they always aim to. They don't aim for a coronal plane. They don't aim for a sagittal plane. They aim for the scapular plane. And you can't, I mean, if you haven't gone through these, but I mean, you know, that's why I've got them labeled. This is the coracoid, and here's the origin of the coracobrachialis and biceps shorthead, as you know, comes from the coracoid. Obviously, the big rounded bulge on the outer part of the shoulder is the deltoid. Trapezius coming down to its clavicular insertion. Now, as we go, we're starting to get the subscapularis muscle, and it passes underneath or inferior to the coracoid process. The subscapularis tendon does. And we know the subscapularis tendon inserts onto the lesser tubercle of the humerus. So somewhere here must be the lesser tubercle of the humerus, or I caught it right there actually, lesser tubercle of humerus. We're getting to the base of the coracoid now, where it's going to attach to the blade of the scapula, getting close to it. If this was the lesser tubercle of the humerus, so identified because the subscapularis goes to it, then beyond the lesser tubercle of the humerus comes the intertubercular groove. So now we're looking at the intertubercular groove and the structure that lies in it, which is the tendon of the long head of the biceps brachii. We keep on going posterolaterally because we're in the scapular plane, and we see now the more proximal part of the tendon of biceps brachii, long head, and the more distal part of the tendon of origin of biceps brachii, long head. We see much of the subscapularis as it's passing inferior to the coracoid, and now we start to pick up supraspinatus as well, for the reason I told you about. We keep on going posteriorly, supraspinatus and subscapularis together. The attachment of the long head of the biceps tendon to what's called the supraglenoid tubercle of the scapula, because this is now going to be the glenoid if we go further back. You can start to see this is the glenoid cavity of the scapula, and this is, again, attachment of the biceps long head to it. And now the biceps long head tendon is running into the upper arm further down. And if we keep on going back, nothing that exciting is happening. Still nothing so exciting. Here's some exciting things. Here's the actual base of the scapular spine, and here's the projecting part of the scapular spine, this part that projects laterally. That means this is the scapular notch, what's called the great scapular notch. These vessels, they're vessels of the infraspinous fossa, is what they are. So they're either directly derived from the suprascapular artery, or they could be derived from the circumflex scapula, because that also supplies the infraspinous fossa. And now we're getting what I think is infraspinatus. The boundary between subscapularis and infraspinatus is very, coming forward again. Here is a very clear subscapularis. Where that turns into infraspinatus is very difficult to tell because the blade itself is so thin. So you're just going right through. And I just thought that looked like it because it looks like it's passing up more over near the top of the joint. Here, actually, all right, let's go backwards. I don't know. Right here, probably, is the circumflex scapular artery. That would be my guess. But I don't know. And then we just head backwards till we have only infraspinatus and the deltoid teres major. And finally, the origin of the triceps long head. A normal person, T1 MRI, T2 fat suppressed. An abnormal person, T1 MRI, same person, T2 fat suppressed. Glenoid, 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 glenoid. Greater tubercle of humerus, head of humerus, greater tubercle head, greater tubercle head. Anybody see anything wrong between what's on the left and what's on the right? These are two normals. These are two abnormals. Same person. Just two different modalities for looking at. Subscapularis, supraspinatus, subscapularis supraspinatus, subscapularis supraspinatus. Well, why don't you take a look at the muscle that inserts right on the apex of the greater tubercle of the humerus? Do you know the name of the muscle that inserts on the apex of the greater tubercle of the humerus? Somebody must know the name of the muscle that inserts on the, yes. Very good. Thank you. Supraspinatus. You see anything odd about the supraspinatus on the right that you don't see on the left?
It looks like it's not attaching to the...
Yes, you are right. Very good. So you probably knew the answer all along. This is a nice supraspinatus. This little black thing is its tendon. Tendon turns out black. All the things that are black on MRIs, cortical bone, air, moving blood, and tendon and ligaments tend to be black. This is all beat to hell here on this person. Now on the T2 you see it even better. It's been ruptured right off. This white standing fluid that you see on the T2, that's just edema fluid. That's just swelling as a result of the trauma to the tendon. This person has a rupture of the supraspinatus tendon. Could not get any clue of this if it weren't for MRI. You couldn't see anything about this on a plain film or a CT. MR is so good for soft tissue injuries, and this is a ruptured supraspinatus tendon.
What's the black stuff on the top of the glenoid? Is that a bicipital tendon?
This right here?
Oh, on the normal folks. No.
Right there?
Yeah, is that a tendon of the bicep?
This is either the tendon of the long head, or the problem. There's a little black thing here. The glenoid is surrounded by a cartilaginous rim, which is called the labrum, and actually the tendon of the long head goes into the labrum. So it's not 100% clear how you could separate labrum from, but I think this is mainly tendon of the long head attaching there. Same problem, different patient. You don't have to make the diagnosis because that word same problem tells you that it's the same. Here's a T1 of the person who's had a ruptured supraspinatus tendon. Here's the T2. And what this shows you is how great T2 is for finding these soft tissue injuries because of the accumulation of the fluid there, which stands out as bright white on a T2 MRI. So this, you look at this, you don't see a black thing, but it's not obvious that there's anything horribly wrong there. But when you see it in T2, you see that fluid there that tells you it's really in bad shape. Now we're going down. I'm not going to spend a lot of time on this. Going down from the top of the shoulder inferiorly. This is the person's clavicle. I'm not going to ask you but one question about this. Here's the supraspinatus. Here's the origin of the coracoid. Here's the rest of the coracoid. Here's the head of the humerus coming into view as we start at the top and head distally. Still coracoid. Here's the glenoid right here, head of humerus. Glenoid, now the scapular blade right here, so this must all be subscapularis on the ventral aspect of the scapular blade. This looks probably infraspinatus on the posterior aspect of the scapular blade. Here's the tendon of infraspinatus actually, so it is tendon of infraspinatus. Keep on going further and further inferiorly, and we now start to see a lesser tubercle of the humerus and the greater tubercle of the humerus come into view. Head of humerus. Glenoid. This little thing here is part of the glenoid labrum, which you'll see the glenoid labrum. On the last day of class, you'll see this thing called the labrum. So the question is, what's that? Here it is here. Lesser tubercle, greater tubercle, black thing between them.
Tendon of the long-headed biceps.
You got it right too. Tendon of the long-headed biceps is exactly right. There it is, sitting in the intertubercular groove. Here it is, emerging from the intertubercular groove, and we don't care what happens to it after that. Nobody?
Tendon of the long-headed biceps, like displaced from
Great.
where it should be?
Very, very good. The tendon of the long head of the bicep is supposed to be sitting right there in that groove between the lesser and greater tubercle. It's sitting here, medial to the lesser tubercle. This is a displaced tendon of the long head, which happens during some various shoulder traumas, especially ones which, because it's usually held in place by a band which extends from the subscapularis tendon. If there's a tear of the subscapularis muscle, that band will tear, and that will cause a displaced long head tendon. I don't want to spend a lot of time on this. But you can study these on your own. This indicates something that is between brachioradialis and brachialis, and that much you should know. Something that is between brachioradialis and brachialis in the upper arm. This is the humerus here. It's a classic relationship. It'll be on the practical. Yeah. Well, radial artery, not so much. No, radial artery comes off after the elbow, distal to the elbow. Yeah?
Is that the brachial artery?
Brachial artery sits here. It actually sits right there. That's where the brachial artery and median nerve are here. Here's the basilic vein in this person. This is something on the lateral side. On the lateral side, between brachialis and brachioradialis. Right, very good. Somewhere here's the radial nerve, probably that dot there, but also there's an artery that goes with it called the radial collateral artery. So I can't tell you for sure which is which here, but that's what sits in this interval. Radial nerve and the radial collateral artery. We go further distally. I'll just point out some interesting things. The actual aponeurosis of the biceps tendon can be seen as separately from the main biceps tendon itself. And we can see a structure which passes deep to the aponeurosis, two structures which pass deep to the aponeurosis and pass medial to the biceps tendon. Another mnemonic that even I use, which is BAN. So what is a? Right, very good. Brachial artery, median nerve. Biceps, artery, nerve. Biceps tendon, you can use TAN if you like, TAN as the mnemonic. Tendon, artery, nerve, TAN, or biceps artery, nerve. So this is the biceps tendon, the brachial artery, and the median nerve. On the medial side, posterior to the medial epicondyle of the humerus, which is right here, what's that? Ulnar nerve. Good. All right. And then we keep on going down. We still see brachial artery, median nerve. We still see ulnar nerve here. And if we keep on, we'll just see the biceps tendon passing to its insertion on the radius. We see the brachialis going to its insertion. We see the supinator, which is this muscle which wraps around the upper end of the radius. So we'll just zip through these. You can look at these later. If this is the brachialis, which it is, this is the ulna. Here's the triceps inserting on the ulna. Here's black cortical bone of humerus. This is the trochlea of the humerus. That's brachialis going into its insertion into the coronoid process and tubercle of the ulna. What do you think that squiggly thing is? What's the anterior brachialis? That's the only question you have to ask yourself. What's the anterior brachialis?
Biceps.
Yeah, which appears biceps tendon. Appears black, very black on an MR. And this is a person who's had a complete rupture of the biceps tendon, right off of its attachment site, and is sitting floating in its upper arm somewhere. And then we'll go through these quickly. This is radius and ulna, just above the wrist joint. I really should have labeled this first because this gives you a very good idea of the level that you're at, because there's only one place where you would find a muscle which runs transversely from ulna to radius, from side to side. That muscle which does that is called pronator quadratus. Pronator quadratus. So this tells you where we are, because that's in the distal portion of the forearm. And as we go distally even further, we see the flexor carpi radialis, and next to it, the palmaris longus tendons. This big mass here is the flexor digitorum superficialis, with its tendons forming within it. And then on the ulnar side, we see the flexor carpi ulnaris with its big, thick, powerful tendon. Deep to flexor carpi ulnaris, we see the ulnar artery and the ulnar nerve. How do I know which is which? Because it doesn't seem that the colors are coming, or the shades are coming out right. The fact of the matter is that the ulnar nerve, as they enter the forearm, is always posteromedial to the ulnar artery, which is given off from the brachial. And that relationship of the ulnar nerve being posteromedial to the ulnar artery, they're far apart in the cubital fossa. They get closer together as you go down the forearm, but it maintains that the nerve is always posteromedial to the artery. So I know this is the artery, and that's the nerve, deep to the flexor carpi ulnaris. Flexor digitorum profundus, one of the deep muscles of the anterior compartment of the forearm, with its tendons forming, flexor pollicus longus, with its tendon forming, and then the muscle that really gave away where we were, pronator quadratus. Keep on going distally. I'm not going to name everything here. Now, you haven't done this, so I'm going to go through it very quickly, but you should know that on the back of the distal part of your forearm, really, here, because here's the ulna, here's the raise, is a band called the extensor retinaculum. You'll see it today in the section, which holds your extensor tendons down so that when you dorsiflex your wrist like that, they don't spring away, like what's called bowstringing. So it holds them down against the back of your wrist. And septa pass from that extensor retinaculum down to these bones and divide them. The orthopedists are very keen about this. Divide this passageway into 6 compartments. They're called the 6 extensor compartments of the wrist. And the first one passes abductor pollicus longus and extensor pollicus brevis. You'll see that today. Second passes extensor carpi radialis brevis and extensor carpi radialis longus. Third passes extensor pollicus longus. Fourth passes extensor digitorum communis and extensor indicus. Fifth passes extensor digiti minimis. Sixth extensor carpi ulnaris. Now here they are. Here are the first 2 in the first compartment. Here are the 2 in the second compartment. Here's the 1 in the third compartment. Here are the 5 in the fourth compartment. Here's the 1 in the fifth compartment. Here's the 1 in the sixth compartment. So you'll see all that in this section today. And we'll just end up, as we keep on going down, you can see the transverse carpal ligament. Does your book call it the flexor retinaculum? Why I don't call it the flexor retinaculum is because 4 or 5 years ago, I did a Medline search for all of the articles written about the flexor retinaculum and for all of the articles written about the transverse carpal ligament, because they're synonyms. And you find that 15 are written about flexor retinaculum and 1,500 are written about the transverse carpal ligament. And in fact, it makes better sense to call it the transverse carpal ligament, because if you call it flexor retinaculum, it implies a similarity to the extensor retinaculum, and they're not similar at all. The extensor retinaculum is simply a thickening of deep fascia. But the transverse carpal ligament is an independent ligamentous structure, not a thickening of deep fascia. So that's why I call it that. But you know that that means this is the carpal tunnel right here. This is stuff outside the carpal tunnel, ulnar nerve and ulnar artery. Take a look at this again. Tell me something that's wrong about it.
Just violated.
What? It violates my rule because I labeled it wrong. Not on purpose, but by stupidity. This is always, the nerve is posteromedial to the artery. So this is really the ulnar nerve, and that is really the ulnar artery. So this is labeled incorrectly. And here is, in the structures deep to the transverse carpal ligament, the structures of the carpal tunnel, the median nerve, which is right up against the undersurface of the transverse carpal ligament. This is flexor pollicus longus. Here are the tendons right here, flexor digitorum superficialis. Here are the tendons right here of flexor digitorum profundus. And that's why here's a nice hook of hamate as we come down. There's other things you can see unlabeled here. These are all your thenar eminence muscles on this side, the hypothenar eminence muscles. Here's a beautiful adductor pollicis on this side. You can see lots of, you can see it's like a dissection. You can see everything. These are all the dorsal interossei here, somewhere on palmar, but I don't know where. And you keep on following, you can see, the independent flexor digitorum superficialis and flexor digitorum profundus tendons as they separate out. Flexor pollicus longus here, and then all the way out to the tippy tips. of your fingers, and then that's it.